Okay, everyone, it's Julie. I am going to do a overview on Module 11, the musculoskeletal assessment, and then I'll do a separate video on neuro. So here we go. Wish me luck. Here are the objectives. Okay, so we're going to go through really essentially just doing a musculoskeletal assessment, how to palpate the joints. Pay attention to things like this. Notice where it says, I'm looking for pain or feeling for pain or swelling, redness, change in temperature, change in range of motion. So we get a good feel for how strong and what condition the patient's skeletal system is in and their muscles are in. We're going to modify the assessment to reflect anything across the lifespan. For us in particular, it's usually the elderly that we're really changing for, and then recognizing anything that would be different from the norm, and then looking at how to document. So just a quick recap on things that you would have learned from anatomy and physiology. So understanding the difference between a ligament and a bone, because that's something that I always used to forget, and I think I mentioned this earlier in class, but a ligament is something that connects bone to bone. Tendon connects muscle to bone, and I always think of a beef tenderloin. That's meat, right? So muscle to bone. So remembering that, and then a lot of vocabulary probably from this unit. We're talking about flexion, which would be bending at a joint, abduction versus adduction. So ABD, abduction, is to move away from the midline. So like my arms like raising from my side up to being straight across, like parallel with the floor. That would be moving away from the middle. And you can remember that by thinking, I mean, terrible, but like somebody was abducted, they were taken away, right? So moving away is abduct. If I have my fingers all squished together and I spread my fingers apart, that would be abducting my fingers. To adduct, ADD, is moving toward the midline. So adduct would be like pulling your arms back from being extended down, back down to your side. So bringing it closer to the midline. Words such as pronate and supinate, when it comes to like your hands and your palm, pronate is face palm up and supinate is palm down. When it comes to your feet, it's easier to show you in class, but if your feet are pronating, that means you're putting the weight on the medial aspect of your foot, like your big toe area is kind of heavier and pushed down more. And supinating, if it's your foot, is you're putting the weight on the lateral aspect of your foot, like your pinky part of your foot. And that would be putting you at risk for like rolling an ankle. You'll see that sometimes like in the NBA or something. Words such as eversion, rotation, protraction, retraction, elevation, depression. So anything that would have been on our vocab list, make sure that we're understanding that, because that's pertinent when we're describing what's happening with the musculoskeletal system. Here are a couple of pictures here too that talk about abduction, extension, flexion, so that things will be a little bit more clear to you. So when we're going to be doing the Unit 3 checkoff, one of the things that we do is we have our partner stand in the room with us straight up and down, obviously, and you're going to stand behind them and you're going to take a good look at the person's spine. So you can see from these pictures, normal spine is all the way through. On the left, it's nice and straight. Someone that has scoliosis, I mean, that looks bonkers in that picture. You can't really tell that it's crooked until you see the person lean forward at the waist. And then you should be able to see some curvature in the spine. That should bring us back to like grade school gym class. They made us do that. So if you see when they lean forward, which you'll have the person do, if the spine or their back looks crooked, that would be a sign that they have scoliosis. And then the two on the right, lordosis and kyphosis, those are important because when we see that, lordosis is like sway back, like your back is kind of arched. Two times that you typically will see people that have a sway back or lordosis, someone that is pregnant or someone that is obese. And the reason is if there's a lot of weight in the belly area, which it would be in both of those cases, the body is trying to balance itself. So the back arches to keep your center of gravity the same to compensate for the fact that the belly is bigger than the rest of the body. So that's lordosis, helps them stabilize. And then kyphosis would be like an elderly white woman with osteoporosis, that hunching that you see in the top of the back where the spine is actually curving forward. The other thing that I want to mention too with abnormalities, this is a little bit off on a tangent, but really pertinent because in clinical you'll see plenty of people with this. If you have a patient that has a hip fracture, they actually fractured like the top of the femur. And with those patients, if they have a fracture, they have an inability to lift, move, or rotate that leg. They can't stand or put weight on it. There'll be bruising or swelling around the hip. And a very common thing is that leg will look shorter than the other leg. And sometimes the leg is rotated outwards. So if you had, God forbid, a fall or something at work, and that's what you would be looking for to see if the person had a hip fracture. We usually take care of a lot of people post hip fractures. And the important thing to know as far as safety is that those patients will be on something post-surgery called hip precautions. And what that means is when we are caring for them in clinical, it is very important that we follow the following directions. Number one, do not let them cross their legs or their ankles when they're sitting or standing or lying down. So the legs should be straight. You're not letting them cross ankles or cross legs or it won't heal properly. And then also the patient should not be leaning forward from their waist, or they should not be pulling their legs up past their waist. So they shouldn't like lift their knees up or bend forward. That's called hip flexion. And we want to avoid hip flexion at an angle greater than 90 degrees, or again, it impedes the healing. One other term that I thought of too is ataxia, A-T-A-X-I-A, which simply means an unsteady gait. You'll see that charted a lot, and you can certainly use that when you're documenting if you have someone with an unsteady gait. So as you know, we always start out with subjective data, correct? In the textbook, it has 8 questions about something like that. Asks about if there's redness, pain, swelling, stiffness, or warmth. You're asking the patient if they've ever been diagnosed with a musculoskeletal disease like osteoporosis, osteoarthritis, rheumatoid arthritis, which there's a difference. Osteoarthritis is just the wearing down of cartilage at the joints. Rheumatoid arthritis is a autoimmune disease that is a swelling of the synovial fluids on the joints, so they become red and inflamed and very painful. So very different diagnoses. And then it asks a couple other things. Remember that I uploaded some documents for when you do the Unit 3 documentation. In that template, it will refer to what table actually talks about the subjective data for musculoskeletal in your textbook. So take a look at that. And then if we're talking about differences between like pediatrics and elderly, again, that would be in the book. But if it's a newborn, you're asking if there was any trauma during the labor and delivery, not to the newborn, obviously. You're asking the mom. Like, was the baby delivered breech? Was it a C-section? Did they have to use forceps when they did the delivery? Does the baby have a click in their hips? So things that would give us some indication as to their musculoskeletal situation. With pediatrics, you're asking about any broken bones, if the parent has noticed any abnormality in the spine or toes or hands, or if the kid has any difficulty walking or jumping, because that can be indicative of other conditions. And then with the elderly, God, it's all about falls and ADLs. ADLs stands for activities of daily living. So that means, like, are they able to get in and out of the shower? Can they make their own food? Can they button their clothes? Can they get their pants on? Can they brush their teeth? Can they comb their own hair? So everything that you would do day to day, you're going to ask about those things for the patient. Do they use any assistive devices like a cane or a walker or a wheelchair? Have they had any falls? How recent? How many in the recent months? Did they have any injuries? Did they bang their head? How is their mobility today? Have they noticed any changes? Can they still make their meals? Can they still do the laundry? Can they still drive? So it's a lot of questions that a lot of times elderly people will not tell you about because they don't want to be, I think there's a lot of fear of losing independence or us taking away their independence at home. So we do have to really make sure we're asking direct and specific questions when it comes to subjective data. All right, so we're going to take a look at this person. And like I said, we already talked about we're going to stand and have them look at the spine, right? So is there kyphosis? Is there lordosis? Is there scoliosis? Or does their spine look like it's intact and correctly aligned? And then it says assess the gait. So what I mean by that is you're going to have the patient walk away from you in the testing room. You're going to watch them like walk to the door. Then you're going to see them turn around and then they're going to walk back at you, and they're going to be looking straight ahead when they do that, and you're observing their gait. Do they have ataxia? Do they have a shuffled gait? Do they seem unsteady? Is their balance seem off? When they turn around, are they getting tipsy at all? Then you have the patient sit, and you're going to take a look at, do the muscles all look symmetrical? Are they sitting upright? Are they hunched over at all? When you're looking at the joints, that's a big one. I want to make sure that when you're doing your assessment, you are looking. So shoulders, elbows, wrist, fingers, hips, knees, ankles, toes, anything. If you're noticing any pain, swelling, redness, warmth, discomfort, deformity, asymmetry, anything that looks abnormal. Obviously, when you're with a student in class, everything's going to be pretty normal, but it could be very different when you have a patient in the clinical setting. And then it mentions range of motion. So here are the things to understand with range of motion. There is active range of motion and passive range of motion. Passive means the patient's being passive. So passive range of motion, the patient's just chilling on the bed and I'm moving all their limbs for them. This would be maybe somebody that is in a vegetative state or had a stroke, or the physical therapist is coming in just to get them to kind of move their limbs, but they're not able to do that on themselves. So passive, the provider, meaning us, is the one that's actually moving the limb. Active means the patient's doing it on their own without assistance. And I think on the next slide, we look at how do I grade that? Because there's a big difference between someone that can barely lift their arm and one that can swing their arm around like they're, pitching in the major leagues, right? So we want to be sure that we're real clear on the level to which they have active range of motion. When we are assessing the muscle strength and range of motion in all of our patients, we would be referring to cranial nerve number 11, which is the accessory nerve. I think I've mentioned before, we have them shrug their shoulders and we put our hands on their shoulders kind of when we're doing our head and eyes and ears and neck assessment. And when they push against us on their shoulders, then that would be assessing number 11 as well. But any kind of muscle strength has to do with cranial nerve number 11. So let's take a look at this next slide. Oh, somewhere in here I have range of motion. I'll just trust that it's here because I know I saw it. So, oh, duh. Julie, this is it. Okay, guys, we're back. I am 100% focused. Okay. Done during inspection. So we're looking at grading the muscle strength, just like we graded the pulses and other things in our previous edema in our other units that we checked off on. So just like edema, when we say the higher the number, the worse it is. I shouldn't say just like. It's kind of the opposite here. So if we're looking at muscle strength, if they would have 0, that would mean someone that is like in a coma, they're not moving, or they're paralyzed, or their body isn't moving at all, okay? Number 1 would be that they're trace like little contractions, little twitches we might see. The patients that we are going to be assessing in early stages of clinical could be any of the following. So 2, active movement only when gravity eliminated. What the heck does that mean? That means that like they can kind of move their limbs when they're laying in bed, but they aren't really lifting anything off the bed. 3, they're moving but not against any resistance, meaning they can lay in bed and lift their hand to get to their call light, but they couldn't do that if I was pressing on their hand. They wouldn't be able to fight against, push against me. And 4 and 5 is probably what you're going to see the most when you're in clinical. So 4 means the nurse is pressing on it, like I would be pressing my hand on the person's, it's hard to describe without being in front of you. Let's just say on the top of their foot, and I tell them to raise their foot, and they're able to push, but it's not very strong. So you would grade that as a 4. Where you see that is, let's say the person had a stroke or an injury on one side, maybe they fractured their left hip, let's say, and you're checking the strength of their feet at the same time, just like we're doing the pulses at the same time. We're always comparing. We're listening to the lungs on both sides. So if I'm checking their range of motion, let's say I'm down at their feet and I'm going to put my hands on top of the top of each of their feet. And I'm going to say, okay, pull your feet up against my resistance. And I'm going to kind of push and they're going to try and lift their feet. If they had their left hip replaced, not like yesterday, but let's say in the past, that left leg might be weaker. So it might be where the right leg or the right foot pushes real hard against my hand. And I'd say that would be a +5 range of motion. It's strong and they're able to push against resistance. If the one on the left is, they can push against some resistance, but it's not as strong as the other leg, I would call that a +4. So we're grading it in that way. And again, we're always comparing to both limbs, both feet, both hands, both wrists, both shoulders to see if one is different than the other. And so when you're going to be checking off on Unit 3, these are the things that we're looking for. Here's a great picture from your book. Talks about shoulders, elbows, and wrist. This person is also having them squeeze the hands as well, I believe. But what I would do is we're going to put our hands on their shoulders. The patient's going to raise their shoulders up. Then I have them do what that middle picture is. I have them put their fists up, and I put my hands on their forearm. And I say, okay, pull towards your body, and I hold it. And then I put my hands on the outside of their forearm, and I say push against my hand, and they try and push. So they're pulling and pushing with each thing that we're testing. And then I think on the left I believe that's the hands. It's kind of hard to tell, but you just have them squeeze. And you can have them like also in assessing the upper body, you can have them circumduct or circumflex their wrists. That means like roll their wrists. And you can have them push your hands against you, like the one all the way to the right. Or sometimes I will have them lay their hands parallel to the ground straight out, and I put my hands on top of theirs and they try and push up. And then I put my hands under theirs and they try and push down. So when I'm doing that, I'm assessing the strength, and I'm assessing kind of the range of motion. Can they circumflex their wrists? Can they raise their arms? Can they bend their elbows all the way in? Can they stretch out their fingers and curl their fingers in? But the other thing that I'm doing is when I'm feeling and listening for, do I hear crepitus? And you're like, hey, Julie, we talked about that when we did respiratory. Yes, that's like a cracking or popping sound, usually due to air in the body, not in the lungs, but in the tissue. So it will happen too when you have like osteoarthritis. You might have popping where things are rubbing against each other in the joint. So I'm listening to see if I can feel popping or hear a popping sound, crepitation or crepitus. So I'm noting that over each of the joints as well. I'm also asking, is there any numbness? Is there any tingling? Because that might be more common, especially in the elderly. And while I'm here, I'm looking, what color is it? Do they have any pallor? Is their color of their skin normal for their ethnicity? Any deformities, any swelling? I think that's everything I can think of. And hopefully we have one on the lower body. Yes, and I mentioned paralysis would be total loss of movement. That would be like a 0 if we're grading things. One other thing I wanted to mention is the 5 Ps. So when we're looking at the joints, we're assessing how is the pain? Do I feel a pulse? Is there any pallor? Do they have any paresthesia? That's numbness or tingling. That's a term you want to make sure you understand. PARESTHESIA. Or paralysis, which would be total lack of movement. And then I think we move on to mobility aids. So let me just touch on the lower body. So hip, knee, ankle, and foot. For this one, you can see on the left, the person has their hands on the patient's thighs. You're going to press down. The patient could try and lift their thighs. And then you can do the opposite. You can put your hands under the thighs and have them push down. And then in the middle on the calves, you put your hands behind their calf and they try and pull their legs back. And then you put your hands on their shin and they try and push forward. And then with the feet, what I always say is, this was actually what I was describing earlier, putting my hands on top of their feet and then they dorsiflex. That means pull the foot up. And then I put my hands underneath and they try and push down like a gas pedal. And that would be called plantar flexion. Plantar flexion is almost like pointing the toes down. Dorsiflexion is pulling everything up. And again, I'm paying attention to if I have any cracking sounds or pain or swelling or warmth when I'm doing that. This I will make sure you guys do in class. I have kind of a cheat sheet and we have crutches and walkers and canes, and I will pull them out and have you practice this with each other because I really think this is the easiest way to understand how to do crutch walking and what it's like to use assistive devices. What I'll say for now, and there will be a sheet in Canvas that says canes, crutches, and walkers, and I'll make sure that that's there for you. Make sure to review that and use that with each other when we're back in class. So A 4-point gait is where the patient can use both the crutches and both their feet, and they can bear weight. They just have kind of generalized weakness. You don't really see that often. A 3-point gait is where the body weight is placed on the healthy leg, obviously, and the other leg is hurt. It's either non-weight bearing or partial weight bearing. And the important thing to understand with crutches is that the crutches move at the same time that the bad leg moves. So if you're moving, you would move the crutches forward with the bad leg, and then the healthy leg would go, depending on where you are. But just understanding that the crutches and the bad leg are going at the same time is important. A 2-point gait is you'd have partial weight bearing on both legs. For these people, usually just use a walker. We rarely ever do a 2-point gait. Swing through is like what you'd see if, in high school, the football player broke his leg or somebody broke their leg in volleyball and, you're young. And that's where the crutches go forward, and then you swing your good leg, you bring your good leg forward past the crutches. You swing your good leg through. Other things I want to point out with crutches are understanding how you navigate stairs, and I'll have you guys practice this with each other with little steps that we have at school too. Remember, up with the good, down with the bad. So what I mean by that is when you walk upstairs, your good leg goes up to the next step up, and then you bring the crutches and the bad leg up to that step. So it's good leg up, then followed by the crutches and the bad leg. It's the opposite when you go down the stairs, down with the bad. So you go down first with the crutches and the bad leg, then your good leg comes down. It'll be a lot easier to show in person. You can try and kind of visualize that, but I want you to practice that with each other. If you've got a patient that's trying to get out of a chair, you put both the crutches on the side of the bad leg, and then they put their good arm on the arm of a chair and they push up to get out. And then when they sit down, the big thing with sitting down in safety is they have to back up regardless of what assistive devices they're using, like a walker or a cane or a crutches. Have them back up so their legs bump the chair. You want them to be as far back to the chair as you can. Then they put the crutches on the side of the bad leg. They use the good arm and reach back to the chair. When we have patients that maybe have a walker, you're going to have them reach back with one hand and the other hand and sit down. If they have a cane, the cane goes on the good side, so on the side that they're strong with, and then the weak leg moves with the cane followed by the good leg, and then you pause in between. And then if we're getting up and helping them stand, we should always be on their weak side. Again, when you go through the sheet in class and you guys work together, this will make a heck of a lot more sense. And then we're looking at documentation. I really want us to be looking at what there is in the book to help guide us as to what we're supposed to write. So here's an example of a patient's documentation. So the patient, remember, we're always using third person, right? We're either saying the patient or the student nurse, which would be capital S, capital N. We're not saying I, we, he, nobody's first name, none of that. So the patient reports no previous history for bone trauma, disease, infection, injury, or deformity. So remember, someone asked in class, well, can't we just write within normal limits? So this is a good example as to why I feel it's really important to say the patient. The other way I would write this is maybe the patient denies history of bone trauma, disease, infection, injury, and deformity. What that tells me is that you asked about all those things. And if someone writes patient is normal, I don't know that you asked them anything. So if you write that the patient, you're always safer to write the patient denies blah, 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 because it tells me that you talked about it and assessed it. Then we go on to no symptoms of joint stiffness, pain, swelling. So I would put SN noted no stiffness, pain, swelling, limited function, or muscle weakness. The patient was able to perform and manage regular daily activities, meaning you witness them getting in and out of the shower, get on steps, whatever they're doing in the morning. And then they are reporting that they're walking. And then when you are doing the assessment, you're writing the joints and the muscles are symmetrical bilaterally. So everything looks normal. There's no swelling, no deformity, masses or redness. So again, it tells me that you did all of those things. Non-tender palpation means you touched the joints and there was no crepitus, no cracking sound. There was full range of motion of the arms and legs with smooth movement. And then we have upper and lower extremity strength is 5 out of 5. That means I pushed on all of those body parts and the person had strong strength resistance against my pushing. So this is a pretty good example of proper documentation. When we do this check off, when it comes to musculoskeletal, the cool thing is we only inspect and palpate. We're not doing any auscultation, right? You don't have to listen to anything with a stethoscope. You're just looking and feeling with all of these things. I think that's pretty much all that I wanted to say on that. The only last bit is I want to make sure you guys understand a Morse fall scale in the same way that we need you to understand a Braden scale, because when you're at a clinical site, you want to be able to assess the patient's risk for falls. This is an obnoxious and juvenile way of remembering the name of which scale goes with what, but I think the easiest way to remember it is like the Morse you drink, the Morse you fall. Like people, and this isn't about people having substance abuse disorder or being drunk, but that's the way I remember. You're more likely to fall the more that you drink. So that's the way I remember the name of the test. But if you can see on here, we're grading the patient. The higher the score, the worse risk they're at for falling. So you're going to ask them, have you had a fall either just now or within the last 3 months? If they say no, you score them a 0. Yes, 25 points already. If you have a history of a fall, you're way more likely of a future fall. Do they have a secondary diagnosis? Well, what in the heck is that supposed to mean? So secondary diagnosis is like a comorbidity. Do they have any other illnesses that would put them at risk for having falls? Like if you have somebody that's got hypotension, they may be at risk for falls. They maybe would have diabetes, where their blood sugar could be high or low, and they could be at risk for fall. So it's if they have other illnesses going on, that's going to put them at risk for a fall. Ambulatory aid, bed rest means they can't do anything on their own. Crutches, cane, and walker is that they use some assistive device. Furniture is the most dangerous. Those are people like my dad, who is walking around with a broken elbow at the time, just grabbing onto chairs, saying that he's fine and that a walker is the last step before death. So he refuses to use one. Is he at risk for a fall? Yes. Is he thick-headed and very frustrating? Yes. Do I love him? Yes. So dangerous to just rely on the furniture is my point. IV and heparin lock, you're like, well, what does that have to do with falling? A ton. Because if they have an IV, heparin lock just means they have a capped IV. You've got an IV sitting there with IV tubing, and you probably have an IV pump, and it's on wheels, and it's attached to the wall because it's plugged in. And if that patient tries to get out of bed with an IV intact, they are way more likely to fall because they're going to forget about the tubing, they're going to forget about the pump and drag it to the bathroom and fall. So it's more dangerous. And then category 5, gait and transferring. Bed rest, meaning they can't move. The difference between weak and impaired, it's a little bit, subjective. But here's what I have found on the difference between these two. Weak, key thing is they're able to lift their head while walking, meaning they're looking straight ahead. They don't have to look at the floor. So they're looking straight ahead. They might have to grab onto furniture. They might shuffle a little bit. They might use short steps, and they're not very strong, but they can look straight forward when they're walking. So not great, but they're able to walk. Impaired means that they definitely have difficulty like getting out of a chair. You know, the kind of person where you see them like 1, 2, 3, and they're trying to pull up, and then they got to sit back down. So takes a couple times to get out of the chair. They have to push on the arms of the chair to get themselves out. They can't just stand up out of a chair. They usually have their head down and they're watching the ground because they're unsteady on their feet. They need assistance, like some type of assisted device, or they're using the furniture, and they may have a shuffling gait or they may have a wheelchair. So impaired is really, they have a hard time getting up without any assistance at all. The weak, they can, but they're not doing great, but they can look forward. So if that helps. Low risk would be 0 to 20 or below actually 25. Medium risk is 25 to 50, and high risk would be a score of 51 or higher. So making sure that you're understanding how to interpret that scale and calculate that score is great. So that wraps up this chunk of the PowerPoint.